and get going. Wonderful. And Julie, I totally have sympathy for you. Thank you for sharing. All right. So obviously we talked about closed captions already. Daryl can't hear anything. Make sure you have your, oh, actually it's nothing we can do on our end. Hopefully the closed captions will actually help you with that you can at least see what's happening. So thank you all for being here. I think we can go to the next slide and hopefully these closed captions comments help. If you want to unzoom Olivia, because we currently are really zoomed in again, or do you need to keep it this way? It looks bigger to me than usual. That's okay. Oh, the presentation, perfect. All right, so as you all know, we are all here because we want to advance the science on Recovery Community Center. Here's the steering committee. Our group, our multi-stakeholder group, comes together to design what the topics are going to be for the seminars and to talk about the pilot funding program we have. And many of them are in the room with us here today. So shout out to them and happy to see you all. Next slide. As you know, our goal is to really bring together different stakeholder groups as we're thinking about the science on recovery community centers. And we usually have a good range here, and I really appreciate that you all come from different perspectives and that willing to share these. So this is who we usually reach. And some of the people who come to our seminar aren't as familiar with recovery community centers as others, which is why we always ground our seminars in the experience of what it is to be a recovery community center. So if we can go to the next slide. Ty, are you ready? Oh, actually, no, I'll get to you in a moment, Ty, but we will have a live feature. Before I go there, our project, which really focuses on recovery community centers and building science around it, is part of a larger consortium on addiction recovery science. And we just provide links here for you all, and you have them in the slides that we'll email out for other programs that are doing other studies, for instance, about recovery housing and for emerging adults and so forth. So there's lots of resources. If you are interested in recovery support services and building science, check out this website, reach out to us. We can help introduce you to folks. So that's why we have a slide here for you all. All right, next slide. And Ty, do we have you with us now? If not, I can go to our polling questions. Perfect. All right. So as I mentioned, we always want to start out with knowing what is a recovery community center. Each center is very different. We are very pleased and honored to have with us today Ty Beckel, who is going to tell us about his recovery community center and what it is like when you walk through the doors of his RCC. All right, Ty, over to you.
Oh, we're all ready, huh? All right, cool. So first off, thank you for having me part of this presentation. And any chance we get to kind of talk about the work that we're doing, where we can share with other people, and then we can learn from others what they may be doing. But we're located in Madison County, Illinois, is where our home office is at. So we're about 20 minutes from St. Louis, to kind of put it geographically. We service 4 counties in the region. 2 counties are really rural, and two other counties are urban. So at our main recovery community center, when you come in, we don't judge anybody. We practice discernment every step of the way, and they come in, and it's a relaxing. We're not running a complete living room program, but it is set up that way. We got couches. It's the paint's calm, kind of a pastel color, to where they're welcomed. We don't require insurance, so if they need help getting whatever it might be, it could be getting into treatment, detox. It could be they need help getting into the food pantry or getting there, or so on and so forth. So our staff are going to typically meet with them. They'll be greeted when they come in the office. They can do the sign-in sheet, and on the other side of the building, there's another organization that sometimes they can go meet with if one of our people are unavailable to get things started. We have some of our paperwork over there, and as we know, we want to meet them with the ability to know that recovery is possible, for one. Two, that 90% of our staff are individuals in recovery themselves or have some type of experience. Our regional recovery community care coordinator she has a family member that has struggled for years, so she's very passionate about helping individuals get the help that they need. So they come in and they can sit down on the couch, they can relax. Typically, we don't have a full kitchen, but typically in the back, we will have TV dinners or something back there if they want to eat. We do have access to showers and laundry, washer and dryer, usually on a first come, first served basis, but it's there. And if they need to do that, do a load of laundry, take a shower, then meet with the recovery coach, they can. And the recovery coach is going to sit down, is going to build that rapport. It's not going to try to rush things. They're going to try to learn what it is they need, because we all have different unique needs, but really our life sustainability needs are kind of the same. We need shelter, we need food, we need support. So you're going to figure out what that individual, whoever they are, again, like I said, and this is a big part of being a recovery community center, is we don't care who you are. We don't care about race, color, creed. We don't care about none of that. We just know that we want to help you find your reasonable happiness. So they'll meet with them, figure out their needs, focus on 12 different type of life domains, and they'll start piecing together a recovery management plan. And we always ask, because we do try to follow the trauma-informed care as an organization. And we're like, what do you need? What is it you need? What do you feel that you need right now, so we can get you the care that you feel that you can benefit from? And they'll piece that together, and then we go to work. If they need treatment, we start going through our network. We believe in the warm handoff method, so we don't just want to hand them off anywhere to someone they don't know. We want to make sure that we get them in front of someone that we know, so we can say, hey, this is so and so, and this is so and so. Let's get this piece together. Let's get this transition to happen. Because I'm a big believer, calling people by their name is important. Even if you're at the grocery store or a retail store, if you see their name tag, I'm always like, hey, thanks, so and so. So let them know that I don't see you just as a cashier. I see you as a human being that has a name. And we take that, we take that kind of model at the Recovery Community Center, and we try to love them and care for them, meet them where they're at, and then start trying to build them up. Teach them about, the autonomy of recovery. Teach them about self-efficacy, that they can make some decisions. We deploy motivational interviewing with them. And in my staff would say, I talk about that all the time. The more and more you do motivational interviewing, it just becomes part of who you are. It's like a sixth sense. And it really helps drive that conversation to help them and get them where they need. And again, that's what they do when they come in and they walk through the doors. It's calm, it's accepting, it's loving, and we usually can help them find results, and by meeting them where they're at. We're getting a transport vehicle today, our first transport vehicle. We got to go pick it up here in the afternoon. We were able to get a grant for Madison County participants, so we're really excited about that. So now we can extend our transportation services even a little bit further. So in a nutshell, that's what it's like at our Recovery Community Center and what happens when people walk in.
That's awesome. Thank you, Ty. And congrats on getting that van. That's going to be great for making it easier for folks to come to you. Wonderful. So we will hear more from Ty later. He's going to be one of our commentators to kick us off in our discussion. As always, feel free to just jump in at any point. But we'll definitely call on Ty in a little while again. Olivia, if you can move us to the next slide. As you all probably expect at this point, we do have polling questions. One of them is just to kind of find out who's in the room, to see what stakeholder groups we have here. And then there's, as always, a question about the actual topic for today's seminar, sort of like a teaser and getting ready for it. So if you all could take a moment right now to go through our poll and answer these questions. So you have to kind of move the slider on the right-hand side down to get to the next question. I'm going to do it now as well. And then once you're done, the submit button on the bottom right turns from gray to blue, and then you're done. All right. And Olivia's going to give us an update when we reach 80% of responses. And if you want some more time, you can also just say. How are we doing, Olivia?
We just hit 80%.
Oh, wow. You guys are all fast. Perfect. All right. So we want to close the polls for us. And then everybody has the ability, I believe, to see the results. So of course, the last question was directly about our topic today. And we asked what you all think about what percentage of substance use disorder clinics currently provide special programs for LGBTQ plus individuals. And most of us thought that that would be less than 20%. And now let's see what we have been able to find to give you the answer to that question. So we took a look at all the substance use disorder clinics, treatment services that are listed on the SAMHSA treatment locator. And this is what we found. We found that 36% of them, or actually 37% of year-round, do have special programs for lesbian, gay, bisexual, transgender, or queer questioning folks. And we also listed as other specialty groups. So you can kind of see like what it is in terms of other things that specialty programs that we have. So that's a little bit higher than most of us thought, but just having a service and how the actual experience looks like is a different question altogether. Today, we are going to be talking about, if you can get us to the next slide, Olivia. Today, we actually have Dr. Abigail Batchelder with us, who is one of our grantees for our pilot study program. Because in our past research, we have noticed that RCCs are particularly welcoming places. Ty talked about this just a little while ago. We wanted to know what is the experience like at RCCs, and also think about in our discussion later how that may be similar or different from the experience that folks have in more formal treatment centers. So Abby, we are very excited to have you here and to have you share with us the pilot project you did as part of our overall initiative to advance the science and recovery community centers. Over to you, Abby.
Wonderful. Okay. Are we going to use these slides or should I pull up my slides?
Oh, do you have different slides?
Well, I think this slide deck.
We can definitely switch. That's no problem for us to stop screen sharing and you can start screen sharing.
Yes, I think they're edited. Let me share mine.
Okay. Beautiful. Just have to get to see everybody for a moment too.
Thank you for having me here as I take a moment to update these. Let's see. All right. So let's see. Sorry.
No worries.
This little bar is in the way. It's always awkward to share. I should have gone with yours. Okay. All right. So yeah, it's a pleasure to be here and to share a little bit about what we found in this pilot trial. Bettina introduced exactly what we did. So I'll share a little bit about the details, but it really was because we saw some higher engagement rates than we might expect compared to other sources of support for people in recovery within recovery community centers among sexual and gender minority people or LGBTQ plus people that we decided to pursue this project. So over the course of this talk, I'm going to give a brief background and a positionality statement just to orient you to my vantage point on this work, as well as I think my vantage point coming to this work, which I think is important. A description of the pilot study that we pursued, a brief snapshot of the results and next steps, and then thank the larger team and welcome questions and comments. I will say please chime in with questions as we go. I think that will certainly make this more engaging during this lunchtime hour for I guess on the East Coast. Okay. So before we move forward, I want to spend just a few minutes defining the scope of what we often consider the LGBTQ plus community. There are many different words and preferred phrases, I would say, to describe people who would be included in relation to these identities. And this is an ever-changing landscape. And it's interestingly geographically oriented too, such that the preferred terms on the West Coast, for example, where I did some of my training, sometimes are different than the preferred terms on the East Coast and everywhere in between. So just so we're all on the same page, sexual identity has been defined or is commonly conceptualized as who someone is either romantically or sexually attracted to, who someone has sex with, or how someone labels themselves in relation to their sexual preferences. And this includes being straight or heterosexual, lesbian, gay, bisexual, queer, pansexual, plurisexual, etc. And there are lots of terms that can be encapsulated in relation to the way one considers their sexual identity. Being a sexual minority, or the term sexual minority, is really an umbrella term that some use to be intentionally inclusive, to kind of acknowledge the ever-evolving scope of word selection, but it is not without challenges or drawbacks either. For example, some people don't like to be considered a minoritized population or minority. So, there are real pros and cons, I think, in terms of the word selection we use when we're thinking about sexual identity. And when we're thinking about whether or not to include gender identity in that. So gender identity is how someone labels themselves or their identity in relation to their gender. So this includes being cis or trans male, cis or trans female, non-binary, genderqueer, two-spirit, etc. And gender minority or gender diverse or gender expansive are all umbrella terms to include categories of individuals who don't identify as cis. So cis, as you maybe know, is identifying the gender that you were assigned at birth. So if I was assigned female at birth and I identify as a female now, I'm a cisgender female. Versus a transgender female. If I was assigned male at birth and then I identified as female now, I would identify as a transgender female. And then, of course, there are individuals who identify as not being male or female, non-binary, etc. And when we think about the inclusion of sexual and gender minority people, a lot of I would say the current research uses SGM as an inclusive term to encapsulate people who are not cis or heterosexual, or not cis or het. So we talk a lot about SGM populations, but again, it has the word minority in it. It's not perfect. Different people have different vantage points on what terms to use. But I think it is important to know that SGM or sexual and gender minority, is preferred by some as a term to be inclusive of individuals who don't identify as straight and heterosexual. Yes, so that's kind of an orientation. There's a lot more written on this. I'm happy to answer questions if folks have them. And please interrupt me. I'm not able to see the chat easily, so if there are questions coming in, shout
We're
out.
looking for them.
Thank you.
We have some comments about people saying hi and where they're from. And if there's a question, we'll be sure to highlight it. And if you everybody, you can just unmute yourself and ask the question as well.
Perfect. Okay, lovely. So now that we've kind of talked about language and the importance of language and the pros and cons and the ever-changing landscape of language, I'll tell you just a little bit about me because it does kind of position, I think, the talk to some extent. So I identify as a queer, white, cisgender woman, and I'm married to a trans man. So for whatever that's worth, that's my identity. Those are some of my identities. I have a longstanding focus on health disparities and public health. So I started working with people with substance use disorders and HIV in the Bronx in around 2007, and have mostly worked in urban substance use and HIV treatment settings in New York and San Francisco before coming to Boston about 8 years ago. And a lot of my work to date has focused on HIV and hepatitis C in the context of drug use. But I really started focusing on sexual and gender minority people in the context of HIV and or substance use around 2014. So it's been a while, almost 10 years, for which a decent portion of my time has been focused on this patient population, or people who identify as sexual and gender minorities. So the pilot project that we did was actually focused on sexual minority individuals' engagement in recovery community centers. And I'm going to tell you why we had that more specific focus rather than LGBTQ+ or SGM focus more broadly in a moment. But what we know that sexual and gender minority people actually, or LGBT people, Q+ people more broadly, report more alcohol and other drug use than heterosexual or cisgender identified individuals. And while most people with alcohol and other substance use disorders don't seek treatment at all, as most people on this call probably know, even fewer sexual minority individuals are seeking treatment. in the literature. Some recent findings show that around 20% of those attending random recovery community centers in the past year identified as sexual minority individuals. And that comes from some data from the Recovery Research Institute with Bettina and others. And this is a notable and higher prevalence than one might estimate based on the US population. So this is really why, as we said earlier, why we pursued this pilot study. I do a lot of work trying to collaboratively work with communities that I'm aiming to serve to adapt evidence-based interventions to more aptly reach individuals. And so one thing that I've been working on is trying to adapt alcohol interventions for sexual minority women and gender expansive people. So this finding from Bettina and her colleagues really was notable to me. And I thought, well, if people are using recovery community centers, maybe there's something we can learn about what is needed in terms of adapting other evidence-based interventions for these patient populations. So that's why we
Just
did
a
it.
quick note, John was the one who led that study.
Oh, thank you, Bettina. Okay. And there are lots of reasons why sexual and gender minority people may require or need slightly different things, and why we wanted to look at recovery community centers specifically in this regard. And I think the scope of those ideas is aptly conveyed in this framework that's produced by the National Institute of Minority Health and Health Disparities. They call it the Sexual and Gender Minority Health Disparities Framework. And you can see on here, everything from individual level factors to societal factors impact the lived experiences of sexual and gender minority people. Probably unsurprising to many, but these are, challenging factors, but also sources of resiliency, which I think are really important to think about as we try to better understand how we can meet people where they're at and best serve them, and figure out what it is that folks are appreciating about recovery community centers, or even that could be better. So this project had two aims. One was to look at some of the data that had previously been collected by John, Kelly, and colleagues to really try to look at differences among sexual minority people within the sample. So there was an R21 that had been conducted, and we did a little bit of a deeper dive into figuring out what might be different or similar across sexual minority people versus heterosexual identified people. And the reason we weren't expansive in including gender expansive people or transgender or otherwise identified people is because the numbers were just so small. I think it was less than 5. So one thing that I consciously didn't want to do is overinterpret a small number, because I don't think that is we might not have found what we would have found if we had done, say, a national study where we really tried to recruit gender minority people in order to get a real perspective of what people thought and reach saturation or get the numbers that we would need to really interpret. So it's for that reason that we focused on sexual minority people. In addition to the secondary analysis of the data that had previously been collected, we conducted semi-structured qualitative interviews with sexual minority people who reported using recovery community centers across the Northeast. And we were very inclusive in our inclusion criteria there. So we included individuals who identified as gay, lesbian, bisexual, and otherwise sexual minority identified individuals. So I'm going to spend the majority of this time talking about the secondary analysis, and then I'm going to share some key highlights from the qual. The secondary analysis is complete, and the qual we're kind of finishing up and writing up. So if anyone has additional questions or wants to follow up on that, I'm happy to share those papers when they're out and more comprehensive. But we did conduct the secondary analysis. I'm conscious of the time, so I'm just going to kind of give you the highlights of what we did. We compared demographics, first of all, across heterosexual identified people and sexual minority people to see if there were differences in terms of who had been utilizing the recovery community centers across the Northeast. And then we looked at recovery status, types of substance use, recovery capital, and service utilization. And then in a minute, I'll explain why we did this, but we also added on content analysis from a question related to facilitators of recovery among sexual minority people versus non-sexual minority people. So here are the demographics. You can see that they're not really different. Statistical significance is indicated by an asterisk, and there are no asterisks on this page. Obviously, the people who identified as heterosexual did not identify as a sexual minority. So these are just broken out here more for descriptive purposes. But you can see that demographically, the two samples were not that different. And what we looked at is we looked at proportion of the sample with specific identities in relation to the total. So we looked at proportion of cisgender male out of the sexual minority sample, for example, and the proportion of cisgender male out of the heterosexual sample. But you can see that the breakdown of the sample, mostly white, mean age across both groups was around 40, majority non-Hispanic. There are more sexual minority women in this sample, notably, than sexual minority men, but these numbers, I don't believe were statistically significant. Okay, so I think the more interesting part, so then we compared, some of these are additional demographics. I just separated them to make it easier to read, but we did see significant differences in education, level of education between the heterosexual individuals who had attended recovery community centers in the Northeast and sexual minority folks. In that sexual minority individuals who had attended recovery community centers in the Northeast were more likely to have some college or more education than their heterosexual counterparts. So that was of note. Some of the demographics were similar. The annual income distributions were similar. This psychiatric history was different, which is notable too. And you know, I can speculate why that might be if folks are interested, but essentially we found that reported lifetime psychiatric diagnosis was higher, meaning that individuals who identified as sexual minorities were more likely to report a lifetime psychiatric history or a diagnosis than heterosexuals who attended recovery community centers. And similarly, they were more likely to report emergency room usage of treatment for mental health care than heterosexual people. Did someone say something? I can't.
I didn't hear.
Okay, I'll keep going. The other difference, significant difference that we found, I guess we found just a couple more. Individuals were asked about their primary substance or the substance that they used primarily, and more sexual minority people endorsed alcohol use as their primary substance than heterosexuals. And more likely to report using it in general in the past, as well as more likely to report using marijuana compared to heterosexuals. Okay, and then when we looked at recovery, I'm just going to move my bar here so I can see the slide. When we look at recovery characteristics between heterosexual and sexual minority individuals, this includes time in recovery, support services, utilized, length of time. We don't see any differences, which I think is notable, actually, that they're very similar in many ways, with some specific notable differences. So we didn't see any differences, and you know, I think these numbers are interesting kind of in and of themselves. But again, what we're comparing is the proportion or the percentage within the 259 heterosexual individuals and the proportion out of, so the number of people out of 68 sexual minority individuals. So definitely fewer sexual minority individuals, but when we look at just the proportions of individuals, as well as the differences between the groups in general in terms of means or central tendencies, we're not seeing differences. Okay.
And for the bottom one, if you wouldn't mind me commenting, if you just go back for the helpfulness ratings, those are actually the means, right? And here you see it's like dead even in terms of the perceived helpfulness of the RCC between these two groups and the sense of community, which is potentially not something you would expect in any setting.
Indeed, I think that's a great point, Bettina. Thank you for making that point. I think that the non-differences is really the main story here. But let me. I couldn't agree more. So because we didn't see a lot of differences, and the differences we did see related to education, and psychiatric history are fairly easy to describe based on the existing literature related to minority stress theory, which I can speak to if folks are interested. We wanted to do a little bit of a deeper dive. So John had included a self-report, an open-ended self-report question in these interviews related to, actually I have the exact question right here. People were asked, what do you consider to be the top 3 things that helped you resolve your problem with alcohol or drugs? And people just wrote them out. So what we did is we looked at them and then we essentially coded them into the like themes listed at the bottom here. To see if there were differences between heterosexual and sexual minority people, to better understand, if there might be different drivers or facilitators. And essentially you can just eyeball this and see that the top 4 were very consistent, with one notable significant difference in spirituality, but the top 4 were the same across groups, such that both heterosexual and sexual minority people reported friends, community and network, spirituality, 12-step programs, and family and children as their top 4 facilitators of recovery. So that wasn't different, but there were a couple of significant differences in that sexual minority people reported a higher proportion of sexual minority people reported spirituality as one of the top reasons or facilitators for engagement in recovery, which may be notable. Education, which is pretty consistent with the demographic differences, I would say, that we saw, in that the sexual minority people were more likely to have a college education or higher. And these numbers are pretty low, admittedly, of folks who endorsed them. And then sexual minority people reported loss. And again, it's a really small number, but did report that more than the heterosexual folks. And that was really the loss of a person, by and large, and in their life that initiated or facilitated recovery for them. So what we found essentially was that
sorry, Abby, I was on mute, but Lorraine actually had a comment. Want to go ahead?
Yes, could you go back to the last screen, please?
Sure.
Okay, so I see that you pulled out the top 3 being friends, spirituality, AA. I see it as friends, AA, and family and children, actually, except for the sexual minorities, higher in spirituality. But my point is, if you look down to RCC, they are the 4th. Everything else ranks lower. So I just wanted to highlight that.
I hear you. Thank you for saying that. The order of this is we can move it. We essentially ordered it by total sample, so total N, which was a choice. I think you raise a really good point, though, that RCCs are really close, right? Yeah, so we could absolutely reorder this. And I think it's good to bring one's attention to that RCCs are a primary source of or a facilitator of recovery for many people in this sample. Yeah, thank you for pointing that out.
You're welcome. I'm going to say one more thing. I raised my hand earlier, but you didn't see it. So I just wanted to make a comment, and this is totally my belief, that the ever-changing definitions of the LGBTQ continuums has impacted the outcomes, because often it changes so much that I believe in the people that I'm associated with don't know which way to categorize themselves, because they're not sure, especially with this new word with the minority, because that can be confusing, saying minority. And also identifying in an emergency room doesn't always who identifies in an emergency room doesn't always reflect truth or fact, because history being the treatment there. So everybody is not always as open. I just wanted to state that. Thank you.
Absolutely. Yeah, I think that's a great point. So I want to address both of those points that you made. One, and I'll start with the latter, the emergency room data is self-report. So you make a great point that that's not necessarily accurate, right? Like that, and we can go back and look at it, but that may be an underestimation, or it might be that folks went to the emergency for potentially something else. But this data right here, lifetime emergency room treatment for mental health is self-report. So what we see here is people who endorsed, yes, I have gone to an emergency room for a mental health reason in my lifetime. So it's around 37% of the heterosexual people and around 55% of the sexual minority people. So, you know, take that for what it's worth, right? Like that's just what people endorsed. It very well might not be 100% accurate. And I think that's a good criticism, a meaningful criticism of most of all the data, right? This is what people reported. And there's wiggle room there in terms of like how we would interpret those definitions and what people considered to be the reason that they answered. So it's a great point and worth critiquing.
I would call it a criticism. I would just, an awareness. That's all.
Yeah. No, I think it's great. Similarly with language, I think it's a very worthy discussion to continue talking about language. There is not a perfect answer here. And I think that so I've worked on the West Coast, on the East Coast, and one of the reasons that I think LGBTQ is not ideal is because there are a lot of people who identify as men loving men and women loving women out there, and that's not necessarily captured. It can be captured in the plus, but so that's tough. But then the use of the term minority, I agree, it can be confusing. What does it include? And these terms are changing in real time, all the time. So it's something that I think the science is always trying to catch up with where people are at and trying to be, well, I guess depending on who you are, some of us are trying to be as inclusive and respectful as possible, right? So people feel like their identities are included, when we think about this work. And I think it's really important for like work like this, where we're just describing what we found. It's even more important, I think, for when you think about resources and being counted and all of that, so it's a work in progress. I think that if folks are interested in language, the APA, American Psychological Association, puts out annually, usually like reports on kind of current state of the language that I try to keep up with. I'm happy to share that with people if they're interested. Not perfect, but like I feel like we can do the best we can do until we know better, and then we know better, we do better, kind of thing. The Fenway Institute, which I'm affiliated with, I'm an investigator over there, puts out language updates sometimes. Those are, I think, a good thing to keep in mind or take a look at, and they do great work nationally. So I feel good about at least the intended inclusivity of those in regards to geographic differences. But it's absolutely a challenge. And it's something I think a lot about and definitely am not perfect on. So I so appreciate you bringing it up.
And we'll make sure if you can send us those links, Abby, we'll include those links in the email that we sent out with all the other materials so that you guys have them and don't have to look them up yourselves.
Okay, let me make a note of that before I forget.
Another point I wanted to add, if you go to the next slide, for where the RCCs, actually one for the bar graph showed up fourth. It's actually higher because everybody who is in this is somebody who is going to an RCC. So I think a lot of the things that you're seeing here in Community Network, the very first one, that's what RCCs do, right? They build community, they help build your social support network. So that's all in there.
It's such a good point. And these categories are imperfect too, right? Because these are our overlay of what people said. This was our best effort to categorize in order to really try to figure out, is there anything or what is unique about the drivers for sexual minority people utilizing RCCs really in service of informing future interventions. So that's the goal here. That's why we did this the way we did. The methods are imperfect in many ways, but I think they were meaningful in that we found that there were a lot of similarities, which I think is really good to know. And I know it's informing some of my work that's happening over at Fenway right now. Like I said, we did see differences in education and alcohol as the primary use primary substance that folks reported, both of which can very easily be contextualized within the literature. There is some literature that sexual minority people, although in like altogether make less money than heterosexual people. They have higher levels of education. And there are well-documented disparities among particularly sexual minority women, but also sexual minority men, but sexual minority women compared to heterosexual women. And you might recall we had a higher proportion of women in the sexual minority sample. So that might account for those differences. The psychiatric diagnosis differences, again, self-report and self-reported use of psychiatric treatment in emergency settings. There is strong evidence that minority stress, and that's what it's been called, that the term can definitely be critiqued, but really put out by Alon Mayer and subsequently many, many others. The minority stress framework or model has really demonstrated with some large epidemiological data that sexual minority people experience stress related to discrimination and stigma that has been associated with negative health and psychiatric health outcomes. So higher proportions of depression, anxiety, trauma, that kind of thing. So this is, the second bullet is also not necessarily surprising in the context of the literature. And then recovery facilitators, as we've been talking about, were also similar between sexual minority and heterosexual people, which I think is important and notable with those differences that I noted in terms of spirituality, education, and loss. But again, the latter two were really, really very small numbers. Where are we at with time? Okay, so really fast qual. We conducted 25 interviews with people who identified as sexual minorities who were engaged in recovery community centers in the Northeast. We were very inclusive, our inclusion criteria. And we asked about facilitators, barriers, and recommendations among some other things. And participants had to be 18 or older, identify as a sexual minority, and report a history of attending a sexual recovery community center. And again, the sample was 25. And I'm afraid we're missing our demographics table. Can I send that, Bettina? Yeah, okay. I can tell you just verbally that we had a pretty good mix of female identified and male identified people and sexual identities. So we had lesbian, gay, sexual, queer, a few pansexual or other identified individuals, but I'm terribly sorry I don't have that here. That was my intention. Okay, so really fast, the facilitators that were identified or things that participants described as being helpful in their recovery at recovery community centers were a sense of community, appreciation of diverse recovery experiences, accessibility, and the range of programs being offered. So I'm guessing these are not necessarily surprising to anyone on this call who knows about recovery community centers. But multiple people in the sample really described coming. I'm not going to read the quotes actually. I'll share these slides and then yes, okay. I forgot we agreed on that to make the time. Barriers that were described in this sample were programming. Some people really described that some of the programming was not as they would have liked or wasn't ideal. Words like misguided, outdated, and not very harm reduction centered were used at times by a subset of the sample. But there was substantial variability across participants. Some participants really did describe programming that met their needs and that they felt very good about. So it was very different, I would say, across by center, by recovery community center for which folks were engaged. Some indicated limited outreach and or programming of specific populations. So there were a handful of individuals who said there was not enough or anything for LGBTQI community members. And accessibility was named by at least a couple of people in relation to transportation and other ways of accessing the recovery community centers. But that was by no means described across interviews. And in terms of recommendations, these were actually fairly consistent across interviews, which was interesting. We heard that signage that conveys inclusivity would be helpful. So sort of visual depictions of inclusivity. disclosure of staff sexual orientations, which was notable to me and the impetus for my positionality statement, or part of it actually, using buttons and or other methods to convey allyship or being a member of a sexual or gender minority or LGBTQ plus identity or community. And then normalization of introducing self with pronouns was mentioned. Additional trainings related to LGBTQ plus or sexual and gender minority people, and working with people in unmet needs, et cetera. And then affirmative care was described in multiple interviews as well. So that's kind of a snapshot of what we collected. We are considering the results in relation to active projects, as I mentioned, focused on optimizing existing intervention strategies for sexual and gender minority people or LGBTQ plus people. We're sharing the results with RCCs that participated in the project. As I mentioned, the quant is under review, so that's done. And then the qual we're still kind of hashing out and anticipate submitting that for publication soon. And once that's done, I'm happy to share that with this group and whoever else may be interested. And this is the team. Thank you, everyone who has been involved. It's a great team of people. And I welcome any questions, comments, ideas.
Perfect. Thank you so much, Abby. In the interest of time, I'm going to move us to our excellent discussants. We will have a half hour after 1 o'clock to still engage in further conversation. For now, I wanted to turn it over to Dr. Lara Weinstein. We asked her to come here as a prescriber and to kind of react to the things that Abby has presented on from her vantage point. Lara.
Thanks so much. It's an honor to be here with all of you. As a family doctor who works with people who use drugs mostly in the community, but I'm also someone who is losing a lot of patients and not to overdose. We're here in Philadelphia and we're losing folks. We've flooded the streets with naloxone. We're losing folks to severe infections, sepsis, limb loss, all related to the poison drug supply that used to be in Philadelphia. The purest and cheapest heroin is now the most adulterated fentanyl and xylazine tranq adulterated product. So I'm very passionate about really transforming the healthcare system to meet the needs of people who use drugs. And I'm not happy anymore with trying to improve the system. What we really need is a full whole-scale transformation. And the folks I work with are often experiencing homelessness and not able to access the existing system except through emergency care, which ends up, even with everybody's best intention, being very, very traumatizing. So as we work to develop this new system of care, we're trying to develop also like a comprehensive program that starts when folks are in the hospital and moves with them through the outpatient setting and their recovery journey. The folks I work with have, a lot of complex medical conditions, and many, because of their sexual preferences and gender identities, have experienced a lot of trauma, have ended up homeless. And we're really working to create an accessible, comprehensive, more welcoming system for folks with severe substance use disorder who are homeless. And I would love to hear from this group about what we can do in this program that we're developing, this pilot program, to incorporate the needs of the folks that we've been talking about even more. So I guess that's a question.
Did the recommendations that Abby shared, did those resonate with you? Did that seem like something that's happening, that should be happening better?
100%. very much so. And even the simple things like, you know, increasing allyship, I think we're finally doing that in medicine. And one thing that we haven't honestly touched on is incorporating a spiritual aspect to our services. So I'd love to hear more about what you think people meant by that, and how that could be broadly incorporated in the services.
I mean, I can just say like what we found in the qual, and I want to just give a really strong caveat that while more sexual minority people endorse that, it wasn't, you know, like that high of a number because of the sample size. So, you know, with that caveat, folks, I mean, I think reported like what we might expect, that there were some people who really felt like spirituality was a driver in terms of their recovery, whether that be organized religion, or we had some folks who talked more expansively about spirituality. So you know, I think that, but it was, you know, like 30 people. So I would just, you know, qualify in that way.
I will say that it's a topic that's come up in our series before about faith-based approaches are important to a lot of people, and we don't see it in all places as much as they are happening in people's lives. And I'm glad, Abby, that you mentioned it's not just organized religions, it's, you know, an expansive spirituality landscape, but it's an important factor in many people's lives in one way or another. Ty, I also wanted to ask you, as an RCC director, what do you take away from Abby's presentation?
I think it was spectacular, and being able to hear from, you know, participants and stuff, I think is really, really important, because that's who we're serving ultimately. Like, you know, most of my staff, you know, we don't really know uh, what's going on with an individual until we get down and we start talking to them and asking them, you know, because like the traditional medicine, I shouldn't say medicine, but traditional treatment, you know, residential and all that stuff that kind of came up in the 80s and 90s was, you know, it was pretty calculated and pretty, you know, scheduled. And here, a lot of what with the Recovery Community Center, we're going to meet them, um, again, like I said originally, where they're at, what they got going on. I really love that, you know, the spirituality piece is a big one that we see with a lot of our people that we're working with, something that they can that they can lean on spiritually, that gives them that kind of that oomph in their daily approach to their recovery, and the connection, you know. And I kind of wanted to make a comment on, um, from our end, this wasn't necessarily with participants, but this was with our staff. My friend Michael, who's part of the LGBT community, who's actually listening, he's going to have to jump off at 12. He's also a spectacular dance instructor as well. Um, you know, he was interning with us through a CPRS program, and we were trying to get space, shared space, up in one of our offices in a rural area. And where we were at, you know, we thought things were going to work out, and then um, the individual where the space was did make a comment about Michael being a gay man. And then at that point, we couldn't, in good faith, couldn't have our office there anymore. You know, just for the individuals that we might see and our staff, we don't want to put anybody in a compromising situation like that. So luckily, we were able to find another office right around the same price very, very quickly. So, you know, in a sense, because, you know, uh, we had to move and make that comfortable for, you know, our staff, even though Michael wasn't going to be necessarily in that office that often. But you know, he was there, and we didn't tell him for a while because we didn't want to we didn't want to make him feel awkward. And he asked me one day why we moved. I said, "Okay, man, I love you. I have to tell you, I can't I can't keep it from you." And I told him, and I don't know if we got a second to let him chime in real quick before he can leave.
Oh, great.
Yeah, and but yeah, and that's kind of our end as a recovery community center. We want to make sure that everybody is welcome, especially our you know, want to be the ally to the LGBT community. So
Wonderful.
if
Michael, are you here? Oh, there you are. Go
yeah.
ahead.
There it is.
Hi, everyone. So thank you, Ty. That was really kind of you. So Abigail, I just want to first say that your presentation was absolutely wonderful. It has my brain thinking about a lot of different things and actually helping me shift my perspective on some things. Because, we're kind of not in a rural area. We're right outside of St. Louis, but it's a very small-minded town. And within this community, my partner and I, we've been together for 4 years and we're both active in our recovery. But the thing is, like, we kind of become like the tokens. So if anyone has any questions about the rainbow community, please go ask Michael or get them here. But I have to say, in collaboration with what Ty shared, he makes it sound as though they were in the conversation process of setting up that collaboration. No, I went in there to help build desks and put them in offices. That's how far along the process it was. And when we moved out of there, it felt very abrupt to me. But at the same time, when I did ask Ty, why did this exactly happen? Because it was a great setup. There are other organizations in this one building. It would have been a great collaboration overall with other organizations. And when he shared with me the reason, not only do I feel as though RCOs having an effort to make their staff feel safe, but in the long run makes the community feel safe as a whole. And so it's more than just, for me, that action was more than just taking care of Michael. At the same time, it was taking care of my community, which this is why I back any RCO that really does do an advocate or a very strong push to make sure everyone feels seen, heard, and cared for. Amare is just one example, but it's a great example because it's the only one we have really around these parts that service as many counties as it does. And so, yeah, Ty, I appreciate you so much. You guys are great. I can't wait to watch the full recording of this, but I got to hop off and I got to go teach. So thank you.
Thank you,
Very
Michael.
good. Thank you for that. I just want to underscore what Michael, you said. I think that one thing that really came out loud and clear across the interviews is that representation matters a lot. And I think that some of us who do like helping professions and work in substance use or recovery spaces don't necessarily feel like, people don't necessarily need to know me and my identities, but that is a huge thing actually. And that we heard about that over and over again in these interviews. So I think you're 100% right. I think that exemplifies one of the main points of this work that I found, that outing oneself or at your allyship is very, very valuable. So thank you, Michael, for sharing that. I grew up in Michigan. I have a sense of where you're at.
Perfect. Lorraine, I saw you had your hand up. Did you still want to chime in?
Hi, no, Bettina, I think I've changed my mind on what I wanted to comment, except I do just want to, here I go. I want to acknowledge Dr. Weinstein's very, very difficult work, and I think one thing that we can do is to help people identify what spirituality means to them, not what spirituality is, but what it means to them. Because when I have found that when seeking spirituality, when thinking about spirituality, many don't know what it means and how to seek it, how to find it. So if we could, help them along that journey, those who want to be on that journey, instead of just them throwing themselves into all of these different self-appointed persons and reasons of and explanations of spirituality, and helping, finding within our circle a way to help someone create their own story of spirituality and identify, just like we do with everything else, to identify for themselves what it means to them. That would be good. I believe we have in the past 10 years, we have thrown everything out there, it seems. And I think we need to begin to rein in a little bit. 1,000 choices can be difficult for someone who has difficulty making choices. So that's what I wanted to offer. Thank you, Dr. Weinstein.
Oh, and thank you. And please call me Lara.
Lara.
Or Dr. Lara. That'll do.
Perfect. We also, on the same topic, we had a comment from Han Ferguson. Are you still here about what you guys are doing in terms of spirituality? Might have had to jump
I
off.
am. Hello.
Perfect.
I got my name tag on and everything. And actually, I've been taking a lot of good notes on the recommendations as well, to bring to my director after this. So I'm very excited about that. But yeah, I've only been working at my RCC for 4 months, but I've greatly appreciated the multiple pathway aspect and everything that's offered. And while there are some things to think about as far as staff having their recovery externally as well, some of those opportunities are offered to staff. So being able to partake in Reiki and yoga and have a meditation room that anyone can sign out. And in that there are a lot of options, and it is self-directed. So we have, all the flyers set out for all of our 12-step meetings and, for yoga and everything. And folks can just, as we give folks a tour, we're like, here's our glorious flyer selection. They can hop in and grab whatever they want and try it out and see what works for them. So self-directed, multiple pathways, and spirituality is probably about 1/3 of our meetings are connected in some way. So yeah.
That's really cool. Thanks for sharing that. And I will, in the name of self-disclosure, say I trained as a Reiki practitioner myself. So that's always bringing a smile to my face when I see it. And I also fully appreciate that there's many different spiritual pathways. So it's one of those great things about the multiple pathways in recovery community centers that they're all welcome, they're all celebrated. Other comments, questions? I know we're at the time where we stop our recording. Now, unless there's a burning comment people want to share with the whole group, we'll end the recording and jump into a smaller discussion. All right.